section 4. I hope this video finds everyone doing well. This will be the block wrap-up that I'll do after the end of every block to kind of summarize what I thought was important, hopefully to kind of give you closure on what we've done, and then looking on forward to the coming block. So this first block was medical screening, and I got to say I really enjoyed the effort that everyone put in. I had you guys all really surprised me. It's interesting how the tones of the conversations change year in and year out. I definitely noticed a different tone there's definitely, or maybe tone is the wrong word, but themes, I'll say themes of conversations that I had not seen before, which I'm really happy to see, and definitely is encouraging for our profession. All right, so I'm going to try to keep these to 8 minutes. I do not. You guys already have a lot of stuff to listen to, so I want to wrap this up as quickly as I can, so you guys aren't taking up too much of your time. Excuse me. So first off, the Goodman article was really good, and it's something that you keep handy. I really feel like understanding these atypical presentations that you'll see in the clinic are really important. This is just one example. Common GI disorders, things that I think are really important that come in and that can present like musculoskeletal pain, the abdominal pain, the dysphagia, the autophagia, the GI bleeds, the epigastric pain, symptoms affected by food, arthralgia, common GI disorders. Well, they're very common. And these are many things that can affect their presentation in somebody who comes into your clinic. And so be aware of those things. And just like the NSAIDs, that's another great box in Goodman that is really helpful in keeping it by your side, so that if somebody were to come in with that, because we know, and I mentioned to a couple of people that GI disorders are far too prevalent, and too many hospitalizations are the direct result of what some people consider benign NSAID taking really end up being a huge issue. So use the Goodman article as a reference, because it's a really good one. All right, the Wayner CTS. So there wasn't a ton of talking about this, just because the questions in the discussion didn't really guide us down that path. But I do think that understanding we'll call it the clinical prediction rule for CTS, the shaking of hands, that's the biggie. In my mind, I'm always asking patients if they wake up in the middle of the night shaking their hands, because that really takes me down the road. The wrist ratio index, not ration index, ratio index, apologize for spelling that wrong. That also, I don't do that very often. Usually I feel like if we get diminished sensation in the thumb, if they're over the age of 45, and the symptom severity scale greater than 1.9, the risk ratio index kind of comes into play later on. Certainly I can do it. I know about it. I have to go get calipers. I don't typically have those handy. But it's good to have in the back of your mind, especially things that should trigger that the age greater than 45 and the shaking of hands. If you get those two, you should probably go ahead and follow up on the rest of it. Now, the positive likelihood with 4 or more is 4.6. That's not even a home run. Anything more than 5 is considered really good. So it's close. It's definitely something you should be appreciative of. And if they have all 5, well, that obviously is a home run. The drawback on it was never validated. So, I think the thing that's important is it's a clinical decision-making tool. It's something that you use, and you may not, you don't hold on to it as gospel, for lack of a better term right now, but you certainly appreciate it, appreciate the symptoms, appreciate that, and it helps you guide your clinical decision making. So we did not talk a lot about Hegedus in the discussion, because it wasn't really, and we're going to talk more about it much more in block 2. It wasn't really part of the conversation in regards to screening, but I think that this Table 2 is really important, and I would keep that by our side. And we're going to dig much deeper into this in block 2, so I'm not going to spend a ton of time, but I do think it's important that what we're seeing is that I said this in a couple of posts, that special tests aren't so special, and I'm going to continue to say that. You'll hear me say that quite a bit. But when we cluster tests together, we certainly get a stronger sense of what's happening. But the definitions can be argued, right? What is a positive impingement sign? What does that really mean? What is the difference between a positive impingement sign and tendinopathy? What is if they have a positive labral tear? what does that really tell us? As you can see, our labral tests are not nearly as good. What does that really mean? What does it really mean to have, obviously, a full thickness rotator cuff tear is important to understand, but it's also important to understand what the outcomes are if you're given that diagnosis in regards to conservative management. And again, we'll be talking a lot more about that in the coming weeks. But if you're not comfortable with the shoulder and you need to better have an appreciation for kind of rooting out what it may or may not be, this is a nice little table. Presentations. In the presentations rather. So in talking about it sounds like everybody's using photo for the most part. There's a couple people that aren't. I am not using photo. For the last 5 years, the director of my rehab department has said, well, we're looking into it. It's expensive. We aren't quite sure or committed. I will tell you that we should probably be in photo because in a major hospital system, we collect outcomes, but the way we utilize them, we might as well not even be doing it. It's kind of a joke. And I've said that this is a joke. We are benefiting no one by doing this. We're really just taking up more time because the nice thing about photo is it's risk adjusted. It gives you a lot of really good information. But the pushback, and I posted this because of this JET article from 2009 that talked about why only 48% of the PTs in practice utilize outcome measures. That was 2009. I think that number is probably significantly higher now. My guess is it's probably closer to 65, maybe 70%. I doubt it's higher than that. But if we look at some of the reasons, the classic kind of complaints, 43% say it takes too much time to complete with patients, takes too much time for clinicians to analyze it. It is a time, it can be somewhat time consuming. Some of these are just kind of excuses. If you're not fully supported within your documentation, it makes it even harder. Obviously, I know that some of those who are in the residency program, or all those who are in the residency program or the fellowship program, are collecting photo data. And hopefully you're finding it useful. I think that this can be really helpful, especially in clinical decision making, to utilize those scores to report back to the patient, well, you were here and now you're here. We are making progress. So do understand that there's a lot of reasons not to use any kind of outcome tools, but outcome tools can be very important. And I thought everybody had a really good handle on the MCID and MDC. I didn't really even feel like I needed to comment. And, the whole concept of pain and the numeric pain rating, that was something that we did not get into. There could be a whole debate on whether we should be asking people about pain. I think one person I talked about, is pain really the fifth vital sign? Should we really be using pain? One of the things that we talked a lot about was TNE, Therapeutic Neuroscience Education, and I loved it. It was great. It's really good to see that ISPE has really gotten out and spread its wings and reached so many people from around the U.S. And so when we talk about how we measure information, so obviously photo, quick dash, those kinds of things are really good. Is the numeric pain rating scale something that's helpful for a patient? I would argue it's probably a real problem, and it probably contributed to the opioid epidemic that we're facing now, when we really put a lot of emphasis on pain and managing pain being below 3 or 4 out of 10. For another time. Again, don't want to take up a ton of time. So with the Boucher article, shoulder pain or dysfunction can look like a true neuromuscular musculoskeletal problem and still have visceral or systematic causes, right? Like you can have a combination of things. This is why it's so important that after every appointment, you are finding an asterisk sign. You are treating that asterisk sign. You are re-examining it in the session. We know that if you see change on that first visit, the likelihood of them getting better is exponentially higher, right? So we want to see change on that first visit. Sometimes you can do it, sometimes you can't. If you can't do it, you damn well better be making sure that when they come back, they're seeing some level of change, and you are monitoring that, and you are making sure that it's directly tied to musculoskeletal function. Clinicians should approach the medical screen with identification of viscera that may contribute or cause shoulder pain. Clinicians should keep in mind that the associated signs and symptoms of each organ that may be a contributing factor, right? In the back of your mind, you'd be like, okay, so what could this be if it wasn't musculoskeletal in nature? What could this be? Is this a rib dysfunction by the right scapula, or are we talking about gallbladder pain? Right? And when does it come on, and how does it behave? These are important questions to be asking. So keep those all in the back of your head. So I got a lot of good discussion about communication and interacting, which I think is, to be quite honest, I'm glad we talked more about that than we did about the Hegedus article, because I think that there's so much value in listening and so much value in empathy, and you see that conversation being talked about on social media. I don't know if you guys are on Twitter. I'm on Twitter. I'm all over Twitter. in the sense that I'm taking in a lot and I'm retweeting. I tweet out some, but I just love taking in. There's so many good people on Twitter in our profession who are really spreading good information, and we talk a lot about communication. And if you're, if you're unfamiliar with Twitter but want to get familiar with it, you could shoot me an email. I can help you if you want to, check out my Twitter handle. Feel free to do so, and not that you have to follow me, but look at the people that I follow. That's always a good indicator, right? Like, who does he follow? That will help you get a better sense professionally, like who to follow and who to understand. Because I love getting research articles. I love the political, or the pearls rather, not political, the pearls of wisdom that are being spread. So the communication, empathy, listening, taking the time. I will say that if you spend that time listening and you get really good at asking the right questions, and I said this a couple of times in different posts, your objective exam is so much tighter because you don't go after frivolous things, right? If somebody comes in and they have shoulder pain and they have concomitant neck pain, and you are not spending a lot, and it's insidious in onset, you're not spending a ton of time, and there's no history of trauma, you're not spending a ton of time ruling out a rotator cuff tear on somebody who's like 50, or spending a lot of time doing labral special tests. You go after it, you know what you want to do, you've talked to them, you know where they are, and your objective exam becomes razor sharp in going in and precisely trying to identify the offending structures, treating them and moving on. And that way your treatment might only be 10, 15 minutes, but you nail it. You find that asterisk sign, you treat it, you move on, you give them something to do at home, and you do all that in 15 minutes, but that you've given them a half hour to tell their story. Huge value in that. So I've already mentioned the T&E. I thought that was really good, that everybody's really digging into that, or not everybody, but a good chunk of people. I haven't heard it talked about on this level by so many people since I've been doing this since 2010. So it was really good. The subjective versus objective. So I kind of just gave you my thing about the how important the subjective exam is and letting them talk. And then the objective becomes, like I said, razor sharp as far as finding out exactly what you need. So good work, everybody. Okay. Block 2. So we're going to roll to block 2, Dropbox. I do want to say that, I loved everybody's discussions. I thought everybody really dug in. I love how early you dug in and you didn't wait till the last week. So continue to do that. Please, 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 please. I'm going to try to get to as many people. Feel free. A couple of people did this, was like, well, what do you think? And what do you think? That is completely okay. Right? If I ask you a question like, well, I think it's this, but I'm not sure, challenge me. Say, well, and then if I say something, say, well, why do you think that? If I don't come back with something, but one of the things that I do want you guys to use is I want you to bring articles to your posts, right? And I saw that some of you couldn't find the articles, but you put the sites in, which is fine. But don't forget to put your articles in Dropbox. And if any of you are confused about how to link Dropbox to your original post or to your responses, please let me know, because I certainly can show you that. Feel free. The FITs are going to be posting their videos of examination, and if you guys have some extra time and want to know what some of the extra work that the FITs have to do, feel free to check out what Scott and Marcos are doing. So I had this don't wait to post responses. You didn't yet. Excellent job. I love it when people start to dig in early in the week. I've had a couple of courses where people wait till Friday, and that's not going to help, right? Like I'm going to ding you in your grade, and it's just going to not allow for great dialogue. I saw some really good dialogue going on. I'm going to try to get everybody some feedback about how the first block went, so everybody feels comfortable with where they're standing. I'm going to try to do that tomorrow night. So Sunday night, Monday night, and Tuesday night. Maybe it'll seep into Wednesday. And no nice jobs, right? Like, I don't want to see that. Don't. A response to somebody, you can do that after the second or third response, but the first response, you've got to, you got to dig in and say, why do you think this? And what about this article? This kind of disagrees with what you're saying. Or look, check out this article. This kind of takes a different vantage point or my experience has been blah, 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 but no nice jobs. And I didn't see any of that. So we're not going to sweat that. Okay. So all in all, great first 2 weeks. I think we're in for a great course. I'm really looking forward to hearing more from you guys. You're going to really love this next block. And if you have any questions, please don't be afraid to drop me a line, because we want to put those to bed as quickly and early as possible. Otherwise, enjoy your weekend, and we'll see you on the other side.